This is Selma Schimmel, and you are looking live at the great city of Chicago, which is once again playing host to the American Society of Clinical Oncology, ASCO. This is ASCO's 49th annual meeting, and this year's theme could not be more appropriate: Building Bridges to Conquer Cancer. More than 30,000 of the world's foremost cancer specialists are here, and so is the Group Room, making our 15th appearance at ASCO and one of our very best. Joining me now is Dr. David Quinn, Medical Director of the Norris Cancer Hospital, co-leader of the Genitourinary Cancer Program for the USC Norris Comprehensive Cancer Center, head section of Genitourinary Medical Oncology, and Associate Professor of Medicine in the Division of Cancer Medicine and Blood Diseases at the Keck School of Medicine. Dr. Quinn, let's just take a few minutes out and talk about some of what's exciting here about testicular cancer.
In testis cancer, we had a couple of really interesting presentations at either end of the spectrum. Two presentations, one from Kristen Kollensberger, who's in Portland, Kristen Kollensberger, who's in Vancouver, in Canada, who worked with the team in Oregon, in Portland, to look at surveillance protocols for non-seminoma and look at what happens long term. At the same time, or actually on the same podium, we had Dr. Mortensen give a great presentation looking at the data from the Danish Tumour Registry on patients in Denmark with early stage seminoma. The good news is that if followed properly, we do not need to give adjuvant therapy to stage 1 disease. This is where the testis is removed and it's got cancer there. And we previously used to routinely give radiation and sometimes chemotherapy for seminoma and chemotherapy for non-seminoma to lots of these patients. And in fact, it was first Dr. Derek Raghavan that pointed out in London that the risk rarely exceeded 50% at worst and was usually less than 20% for these patients. And then that has led over 30 years to us doing surveillance. Now, the problem with surveillance is you need people to cooperate and actually come and get some scans. And each of the studies showed that our scanning frequency can be less with less exposure to radiation. So I think that we're evolving our treatment paradigm for the majority of testis cancer patients who present with stage 1 disease, where we hopefully can observe them and not give them the toxicity of either radiation or chemotherapy. So that's good news. At the other end of the spectrum, we have poor risk patients. And everyone thinks that we cure everyone with testis cancer, and in actual fact we do a really good job. But unfortunately, we still see patients that have poor risk testis cancer, and they're patients that, in fact, it's not just testis cancer, it's germ cell tumours because they occur sometimes in the back of the abdomen or the chest. And they're patients that can present with liver, bone, or brain metastases when they're diagnosed, or they have really high markers in their blood. And whilst we've been successful with chemotherapy and they do better, our standard chemotherapy produces cure rates of only about 50% in that group. So they have a 50-50 chance of dying. So what we saw at this meeting were two presentations. One from Dr. Fazazi from France, a French study in which they looked at giving standard chemotherapy at the start to these poor risk patients and then switching to continue standard therapy or give them something different if their marker did not fall in the blood optimally. And what he showed was that we need to give these people something different if their marker doesn't fall. Now, the French regimen was very complicated, and most of the community oncologists were kind of looking at it with all these alternating drugs and saying, I don't know whether I can actually do that. And the study took almost a decade to do. And it showed very, very good data, a really fantastic presentation. Subsequently, Darren Feldman from Memorial Sloan Kettering Cancer Center in New York presented some data on a study that we did with them. We participated in at USC, and that showed a very good response to upfront use of novel chemotherapeutic drugs, including Taxol and ifosfamide. And it may be that we're going to meld these things together. In this area, we are looking at better treatments for the testis cancer patients, even with metastatic disease, to try and reduce their toxicity, and also in this group to try and cure more of them up front. The important thing out of Dr. Fazazi's study is that he showed a significant reduction in the need for subsequent high-dose chemotherapy and stem cell support. So this is probably economically viable and also avoids a significant slug of patients needing to go through that high-dose therapy, which is actually very toxic.
Thank you so very much. Dr. David Quinn, Medical Director of the Norris Cancer Hospital, co-leader of the Genitourinary Cancer Program for the USC Norris Comprehensive Cancer Center, head section of Genitourinary Medical Oncology, and Associate Professor of Medicine in the Division of Cancer Medicine and Blood Diseases at the Keck School of Medicine.
Thank you very much, Selma.
Thank you, Dr. Quinn.